am here to present a talk by Dr. Blas, brought to you by the Global Health Institute and the Global Health Alliance. So the talk is going to be about the Mamás del Rio, Mothers of the River, mitigating the impact of SARS-CoV-2 and improving maternal and neonatal health in rural areas of the Peruvian and Colombian Amazon. Our presenter today, Dr. Blas, is the director of Mamás del Rio, Mothers of the River, a social innovation program that aims to improve maternal and newborn health in rural and remote areas of the Peruvian and Colombian Amazon region through the training of community health workers empowered with technology. Dr. Blas is an associate professor at Universidad Peruviana Cayetano Heredia School of Public Health and an affiliate associate professor at the Department of Global Health at the University of Washington. She studied medicine at Cayetano Heredia Peruvian University and finished her MPH and PhD in epidemiology at the University of Washington in Seattle. Dr. Blas is a recipient of the 2009 to 2010 Fogarty International Clinical Research Fellowship and the 2010 Global Health Council's New Investigator Award. She has been awarded the 2016 Elsevier Foundation Award for Early Career Women Scientists in the Developing World, the 2016 L'Oreal UNESCO Concitec Award for Peruvian Women Scientists, and the 2016 Award for Good Practices in Public Administration for the Mamás del Rio project. In 2018, Dr. Blas was a recipient of the Women in Innovation Award from UPCH and the 2018 Eisenhower Fellowship. In 2019, Mamás del Rio received the Social Innovation and Health Award from the Pan American Health Organization. And with no further ado, I'm going to hand over to Dr. Blas to continue the presentation.
Well, thank you very much for that introduction, and thanks to the Global Health Initiative and the Global Health Alliance of the University of Arizona for inviting me to give this talk about Mamás del Rio. So Mamás del Rio means Mothers of the River. So you will hear me a lot saying Mamás del Rio, maybe in Spanish, because that's the original name of the program. So today I am going to talk how our maternal and newborn health program had to adapt to fight COVID while continue promoting maternal and newborn health. And I will start by showing some slides about my talk. So we're going to talk first about a little bit of background on how is neonatal health worldwide. Then I will mention our formative research, what is our proposed solution, what are we doing with the evaluation, the preliminary results that we have so far, how was our process of scaling this project to Colombia, our COVID-19 response, and I will end up with a conclusion. And if we have time, I will show you a 5-minute video about Mamás del Rio. So let's start with the background. How is neonatal health worldwide? So if we see neonatal mortality globally, there are 17 deaths per 1,000 live births. And if we, as we see in the graph, there are large regional disparities, right? With Sub-Saharan Africa, with 27 deaths per 1,000, Latin America 9, North America and Europe 3. And how is in Peru? In Peru, we have seen reductions in neonatal mortality from 16 to 6 deaths per 1,000 live births between 2000 and 2019. And you may say, oh, you are doing well as a country, but no. If we just we get closer and we see only this region of Loreto, which is in green, the area where we're operating, we can see that Loreto has the second highest neonatal mortality in Peru with 19 deaths per 1,000 live births, but that is in the whole Loreto, if we take an average. But if we look closer at rural communities in the areas where we operate, we can find neonatal deaths of 31,000 per 1,000 live births, similar to other countries in Africa. And the causes of death are all preventable: infections, asphyxia, and prematurity. Now, for community-based interventions, we can use several delivery platforms. No? We can choose facilities, improving care at birth, emergency care by skilled personnel, or we can work in communities, working with women groups or community health workers. So we decided to go with the community health workers. Why? Because several studies have shown the effectiveness of community health worker home visits to reduce neonatal mortality. And we can see these two meta-analyses, one by Goggia in 2016 with 5 cluster randomized controlled trials from South Asia that show a 25% reduction in neonatal mortality with the home visits by community health workers. We can also see the study of Hanson in 2017 with 8 cluster randomized controlled trials from South Asia and Sub-Saharan Africa that show a 11% reduction in neonatal mortality. However, the effectiveness is context specific. It depends on the local setting, so where we are implementing. We have not done this type of studies in Peru. This is the first study. It also depends on the intervention design, how we're designing our study, how we're doing, what is the methodology, and also on the strength of our implementation. So in Mamás de Rio, we are focused in maternal and newborn health, more on newborn health. And within newborn health, we are focused on essential newborn care, which you will hear it a lot in my presentation. So what is essential newborn care? Essential newborn care are the practices related to clean delivery, hygienic core care, thermal care, and breastfeeding. And meta-analysis and Delphi panels link these essential newborn care practices to a reduction in neonatal mortality due to infections, prematurity, and hypothermia. And in fact, essential newborn care is a principal component of community health worker home visit programs. Now, you know how is neonatal mortality in the world, in Peru, how is in rural areas. You know that we are doing very bad in rural areas in the Amazon. So what was our formative research? How we started? So I first applied for funding. It was a small pilot, and that was funded by Grand Challenges Canada and the Peruvian Council of Science and Technology to assess the feasibility of training community health workers on the use of mobile devices. And I decided to go to Loreto because, as you have seen, it has one of the worst health indicators in Peru. And I decided to go to rural areas and remote areas in Loreto, which are along the river. So the first pilot of Mamás de Rio was done in 13 communities along the Marañón River in Parinari. And I decided to go to Parinari because it's a place where there were community health workers trained due to previous interventions like the Programa Buen Inicio or Good Starting by UNICEF. So there were already seeds planted. And what we found is that community health workers were willing and were able to learn how to use mobile devices to improve maternal and newborn health. And in this time, we tested the intervention with cell phones and a very simple application. So that was our pilot, and then we applied for an additional grant. So we got the scaling up by Grand Challenges Canada and the Peruvian Council of Science and Technology to implement Mamás de Rio in a bigger area and to improve the intervention. So we started this new phase of Mamás de Rio by doing a study on the home birth preference, the childbirth, and the newborn care practices in rural Peruvian Amazon. So we traveled to the community, we live in the community, and we conducted 60 semi-structured interviews with women who delivered within the last year, their partners, their relatives, traditional birth attendants, and community health workers. And what we found is that the home is the preferred place to deliver, basically because it's comfortable. You are surrounded by your family during your delivery. There is no need for transportation, so you don't need to spend money and to leave your children, because in average, a woman has 4 children. So the home was the preferred place. And one interesting finding that we had is that if you're a brave woman, and that's what the women say in the community, if you are brave, you will deliver at home. But if you are a weak woman, you will end up delivering in a healthcare facility. So you see, women who deliver at home have a higher status than women who deliver at a healthcare facility. And we understand with this how hard, and also after visiting the health facilities, how hard it is to improve and to increase the delivery at the healthcare facilities in rural areas in the Amazon. So the other findings that we had is that deliveries usually occur in the floor. And actually, this is the picture that we took after a delivery. There is no skin-to-skin contact or early breastfeeding. Basically, you deliver and they put your baby on the side, and family focus on women, on the pregnant woman. And also one interesting finding that we had is that the women discard the colostrum because they think it's harmful. So they recognize this is yellow. The colostrum is the first milk that we have after we deliver. So they say it's yellow and it will be harmful for the baby. And this knowledge passed from generation to generation. So women discarded. 60% of women actually discarded the colostrum. So this is why we included the importance of giving colostrum in the pieces of communication that we have in Mamás de Rio. And I will show you in a few minutes the results on this particular indicator. Also, the cutting of the umbilical cord is done by the godmother, and this practice is super important. The godmother will be the person who will be with you after your delivery. Basically, she will give you food, she will clean the floor. I have seen godmothers doing that after the deliveries. And if you die during your delivery, the godmother will help raise your kids. So you see, godmothers are super important. Who will want to lose a godmother? This is the reason why when women go to a health facility, and sometimes the health facilities don't allow an additional person, so don't allow the godmother, in the delivery. So women don't want to deliver. That is one of the reasons why women don't want to deliver at a healthcare facility. The other finding that we have is that traditional birth attendants attend 50% of the births at home. The other 50% are attended by a family member. So this is the reason why we do two things in Mamás de Rio. We train traditional birth attendants on how to do a clean delivery. But we also request women that when they are visited by the community health worker, the person who will attend the birth be during the visits, so that she or he can learn how to do a good essential newborn care. Now, in summary, so we have a high proportion of home births in the communities where we operate. In this baseline census, we found a 64% of women who deliver in their home. Women deliver under poor hygienic conditions, and there are huge gaps in essential newborn care. We have a very young population with a low level of education. 50% have only primary school. They are in extreme poverty, and they have a high fertility. The health facilities where we operate, 50% don't have a nurse or doctor, are very poorly equipped, and lack of basic infrastructure. So facilities don't have access to running water, electricity, or sanitation. And yes, we found community health workers before our intervention, but they have a very inconsistent training by the Ministry of Health. So basically, sometimes they train them, then they leave them for many months without training. So it's super inconsistent. There is not training focused on maternal and newborn health. The training that they receive is mainly focused on malaria and dengue. And there are no structured activities for the community health workers. So basically they don't have like a specific duty that they have to follow, and there is no supervision at all. So this provides us an opportunity to conduct a community-based interventions with community health workers to improve essential newborn care practices. So then with all of this, we had to build, what is our solution? So our solution is to build a program, which is Mamás de Rio, where the core of the program, the center, are the community health workers who will do home visits. The community health workers do two things: surveillance, so they identify new pregnancies in their community, and they are capable of doing pregnancy tests. We train them for that, and they register the woman, and then they start the home visits, 3 during pregnancy and 3 after the delivery. And also they refer women for the prenatal control to the health facility. They use the tablet that has an application that helps them deliver health content to women and their families in the form of pictures and videos. Some of these videos have been created through a process of photo voice and storytelling. You can find also that in our publication. And they also use the tablet to collect data. So for example, they collect the ID of the woman, if the woman wants to deliver at the home or at the health facility, if the woman had a prenatal control or not. If not, he or she encouraged the woman to have prenatal controls and to go to a health facility. And also they have scales to weight the child, the newborn, and they insert that in the tablet. So that is the heart and the core of our program. Now, this core of the program, which are the community health workers, are supported by other interventions. We train traditional birth attendants. I mentioned how important are they for providing a clean delivery at home. We also train healthcare personnel in the sensitization and on the importance of supporting the work of community health workers, because we can train community health workers, but once they refer women, if the healthcare facilities disregard their work, it's like we did nothing. So it's important also to train the healthcare personnel, and of course we train them on essential newborn care. We also conduct community sensitization at 3 levels. We talk first with the leader of the community, then we talk with all the community, and for example, in these talks we emphasize the importance of supporting the work of community health workers, because they, community health workers, have been chosen by the community, but they will visit pregnant women who are female. So the community has to accept that a man will visit a female. And this is important for us. And also we talk about the support that they should give to the community health workers. And also we talk with women of childbearing age in these sensitizations. And we talk with them about the importance of reporting when they miss a period, so that the community health worker can do a pregnancy test and enroll them in the program. So the community sensitization is done by the supervisor. She's Camila, doing a sensitization with the community health worker. We also have one important piece, which is a supervision, in which a nurse technician, all females, travel once every 2 months to the communities to provide feedback to the community health workers. And in the months where they don't travel, they do the televisits, which are remote supervision. And we had to implement these remote televisits due to COVID, because we were not able to travel in the river. So after that, we decided to do a mixture of in-person and remote supervision to also lower our costs. So in summary, these are the components of Mamás de Rio. We have a community component where we train community health workers to do home visits to pregnant women and newborns. We train traditional birth attendants in essential newborn care, and we do community sensibilization. And we have a health facility component where we sensibilize and train health staff on essential newborn care, all supported with a supervision component. Now, if we zoom in the activities of the community health workers, they do the identification of new pregnant women using pregnancy tests, and insert and report the woman in the tablet, and they do 3 home visits during pregnancy and 3 after the delivery. They use a mHealth application that has a standardized content. They has didactic support with images and videos, some of them co-created with the community. Community health workers have also a birth and emergency plan, essential newborn care educational cards, and danger sign posters. So we have 4 posters, for example, about danger signs during pregnancy, during the delivery, in the postpartum period, and also danger signs for the newborn. And they have pregnancy tests and clean delivery kits, and also they have scales to weight the newborn once he's born. So this is how community health workers collect the data. They collect the data from pregnant women and newborns. Then if they are in an area where there is internet, they send the data to the cloud. And if there is no internet, the supervisor travels to the community, uses Bluetooth, and then when she travels to an area with internet, which is usually Nauta, 2 hours from Iquitos, then she uploads the information to the cloud. Our application doesn't need internet, so it can be used offline. And with this, then we have a map with where are the pregnant women, the location of the pregnant woman and the newborns in our area of operation. So how about the evaluation? So we are evaluating this program and we have 2 objectives. One is to do a before and after study to assess changes in essential newborn care practices and healthcare seeking over a 2-year period using repeated household censuses. That is one of the objectives. And the other objective is that we're doing a mixed methods process evaluations to assess the coverage of the program, the intensity of the intervention components, and explore contextual factors and elucidate mechanisms. This work is being conducted by Stefan Reinders, who is doing actually his PhD thesis for the London School on the evaluation of Mamás de Río, and you can find the protocol of the study at the bottom of the slide. So you see here all the intervention components that we are assessing in a qualitative study and quantitative studies. So basically, for example, these are the community health workers who conduct surveillance, who then identify pregnant women and do these visits, improve essential new worker practices, and this reduces neonatal mortality. So we are assessing all of these components through interviews, focus group, and observation to see if a component, how it's working, and if it is working. That will complement the before and after study that we are doing. So this is the study area. We are working in 3 out of 53 districts in the region of Loreto, in Nauta, Parinari, and Saquena. These are the rivers. And we are working around 350 kilometers of the river, so it's a long extension. We have 2 health centers in yellow and 18 health posts that have a very difficult access, mostly by a peque-peque, which is a wooden canoe. So if you live in these communities and you need a C-section, you have to travel around 12 hours by a peque-peque until Nauta, and then a 2-hour drive to Iquitos. This is the only place where you can have C-section. So these are pictures that I took of the health facilities so that you understand where we operate. And basically the access to the health facilities is very difficult. It's very costly because of the gasoline that has increased a lot. And it's dangerous because these are how people travel in peque-peques, which are wooden canoes that can easily flip over. The health facilities are poorly equipped. They don't have access to running water, electricity, or sanitation. And this is the picture that I took of a health facility that was flooded. So there is water in the health facility. So you are supposed to deliver, if you want to deliver the health facility, here. Now, regarding the preliminary results, I will mention in the interest of time 3 results. One was the increasing knowledge of community health workers with the pre and post-test evaluation. Then I will mention the coverage of the intervention and the results of the census we conducted in 2020. As I mentioned, we are right now conducted our last census, and we are going to have the results the next year. So, how was the knowledge gain in community health workers? We did a paper test with 20 items, closed-ended multiple choice questions to assess the increase in knowledge in healthcare seeking and in essential newborn care. All community health workers completed the tests, which was super great, and that this was thanks to the work of our supervisors and coordinator. And as you can see, there was an increase in healthcare seeking knowledge. No? So for example, community health workers now know that the newborn needs a control within the next 24 hours of being born. Also, we have seen dramatic increases in the knowledge of skin-to-skin contact and the importance and on the importance of immediate drying of the baby and the colostrum, no? The importance of give colostrum. Now, in terms of the coverage, we measure this using the list of the community health workers during the training and the supervisor reports. We have a longitudinal database that shows when a community health worker drops and why he left the program. So you can see here in blue the effective coverage, no? So the community health workers present in a community, and you can see that is more than 90%. So these measures, even the community health workers, communities where community health worker drop, but we train a new community health worker. So it's more than 90%. And actually we do one of these trainings on new community health workers every year. In yellow, you can see the initial cohort of community health workers, which are the ones who started from the beginning of the program, and you can see that it has decreased a little bit, but is higher than 75%. And you can see in overall that the coverage of our intervention is good, although we don't provide payment to the community health workers. We just provide, of course, with all the materials, the tablets, t-shirts, caps, etc., and a $15 incentive to attend to the trainings. So these are the results on the newborn care practices reported by women between 15 to 49 years who had a live birth at home at baseline here in gray, and before and after the lockdown in blue and in light blue. And you can see here the increases, for example, in the percentage of newborn with immediate skin-to-skin contact who have increased a lot, and in the percentage of newborns with nothing harmful applied to the cord. In the community, they usually put herbs around the umbilical cord, so we see here an increase. Also, regarding breastfeeding, we can see an increase in the percentage of newborns with colostrum feeding that has increased from 40% to 80%, and the percentage of newborns with early weaning that increased from 30% to more than 70% before and after the lockdown. So these are important findings. Also, regarding how the community health workers are operating, they are doing good. So when we ask women if a community health worker conducted a visit during your pregnancy, basically it increased from 10% to more than 60%. If they receive any educational material, before was 0, before the starting of our program, now with more than 50%. And also the percentage of women with a clean delivery kit increased from less than 10% to more than 60%. It decreased a little bit after the lockdown, but not too much. So as you see, even after the lockdown, after our president declared an emergency, no one can leave your home, the community health workers keep working, and also our health centers cease their operations. The community health workers were the ones who continue providing maternal and newborn health. So in summary, our interim data suggests that the intervention can improve essential newborn care practices, as we have seen in the results. There is a good coverage and intensity of the intervention among the communities. And also I want to highlight the importance of the process evaluation that we're doing. Remember all the components that I mentioned? Yes, we are going to have quantitative results of how essential newborn care coverage or essential newborn care practice improve. But with the process evaluation, we will know how were the processes within a certain area. So for example, what happened with the community health workers who drop out, why they drop out, how was the work of traditional birth attendants, how it was perceived by the women of childbearing age, among other things. So this will allow us to improve our program. Now, how was the process of scaling of Mamás del Río to Colombia? So I have shown you how is the evaluation of Mamás del Río, our results. So some years ago, I was invited by the Ministry of Foreign Affairs of Peru to give a presentation of Mamás del Río, and they liked the program because it was done in rural areas in the Amazon, which are the borders, and they are in charge of our borders. So they decided to invest in the program. They talked with Colombia, and we applied for the binational plan Peru-Colombia, which is funded by both governments of Peru and Colombia, and both governments have to agree to implement an intervention. So after 3 years, the change of 3 presidents, several political problems in Peru, the change of Ministry of External Affairs, we were able to implement this program at the end of the last year. So we're happy to say that now Mamás de Rio have crossed the borders and we're operated in the Amazon area of Colombia. So this is what I just explained. This is our operation where we're doing the evaluation of Mamás de Rio in these rivers, Marañón, Ucayali, and Amazonas. But now, thanks to the Binational Plan Peru-Colombia and the Inter-American Development Bank, we are operating here in the Putumayo River, in the border between 2 countries. So now, Mamás de Rio is a program that is uniting 2 countries due to health. And we are operating in 4 districts, 2 in Peru and 2 in Colombia, in 30 communities, with a total extension of 400 kilometers, 50 kilometers more than here. This is the picture of the first training that we did in Peru and Colombia. In Colombia is participating and has a lead role, the Ministry of Health of Colombia, as well as Etnolano and Isegoría, who are implementing this program in Colombia. So this was the training in the 2 countries. I am glad to say that Colombia chose to train only female community health workers, and actually we're learning from that experience since we are going to do the evaluation of also this binational program. This is a picture of a community health worker in Colombia driving a speedboat, super empowered. And I am glad to say that they adapted the program to the Colombian system with some changes. So for example, one of the things is that Colombia allows abortion. So in the first visit, where in Peru, we talk about your delivery and emergency plan, they talk only about the emergency plan, not the delivery, because women have the right to do an abortion. So some of these changes happen, and now community health workers are trained to work with the insurance system in Colombia. It's a different system than in Peru, to guarantee the access of women to healthcare. So we are super excited that now Mamás de Rio is in Colombia, and the name of the program is Mamás de la Frontera, which means Mothers of the Border, which is the name that the Ministry of Foreign Affairs of Peru wanted to give to this project in the border between Peru and Colombia. So now I want to say what it was our COVID response, and we had 6 actions for COVID. Once COVID hit Peru, we had to think fast, and of course we had to apply for funding, because we are not the government. We don't have funding for a different thing than maternal and newborn health in this case. So we got funding from Grand Challenges Canada and the Inter-American Development Bank, and we were able to ship prevention material to more than 16,000 people in 6 Amazonian rivers. We send educational materials that promote basic knowledge on personal and community prevention about COVID. We send posters, flyers, audios, and videos. We also send posters about hand washing, and some of these flyers were adapted from posters from indigenous federations with their permission. Also, we send instructions on how to do face masks. And we send supplies like soap and reusable masks for every member in the community. This is a picture of us traveling to the border with Colombia to deliver this material. Here we're talking with the APU of Maridicay, and we're giving them the material to protect from COVID. So once we were able to go in person, this is a picture in Colombia doing a workshop of how to do face masks. Also, we established a COVID protocol in the daily activities of the community health worker, and this was reflected in our data showing that community health workers keep working and keep delivering educational material and safe delivery kits. So for example, we show them how to prevent COVID in the community and among them, and among the families that they visit. We told them about the hand washing and cleaning of the tablet, about the importance of this, about the importance of doing the home visits outside home, maintaining a physical distance, evaluate symptoms, and if there are symptoms, he shouldn't do the visit. what to do in case a community has symptoms or a certain person, and they use masks for all participants in the visit. Also, we promote a community-based plans in response to COVID. So we train the community of how to identify possible COVID cases, isolate these cases, and then refer them to the healthcare center if needed, and promote COVID testing at the health center. Since we weren't able to travel in person, so we weren't able to do the training in person, we designed a distance video-based training with 9 sessions and 39 videos that you can use, and also you can find in this link. And this was to supplement or replace the training. So all the trainings that we did in person, we decided to do it now on videos, deploy on tablets. So we send tablets to the border with Colombia with all of these videos where community health workers can learn all the topics that we do and we teach in the trainings. We also got funding from the Peruvian National Council of Science and Technology to develop an active vigilance systems for COVID based on community health workers empowered with tablets. So in this case, the community health worker was trained to teach the community how to prevent COVID and to identify patients with symptoms of COVID or with complications and refer them to the healthcare facility. One of the most important things that we have done is to train the community health workers on the importance of the COVID-19 vaccination. So the vaccines arrived in Peru super late, many months after the US started their vaccination. And we trained them on how important is to promote the vaccines, because there were a lot of misinformation in Peru. For example, saying that one vaccine was better than the other and that you should not get vaccinated with a certain vaccines of a certain country. So we had to train them on how important were all the vaccines. And now the community health workers have become advocates in their country. No? They coordinate and they organize their community before the arrival of the vaccines. They set an examples by getting vaccinating themselves first in the community, and they also can coordinate the arrival of more vaccines if needed. So, as a conclusion, I will say that the community health worker program that we have can improve essential newborn care practices in rural communities. Our intervention in Mamás de Rio was able to adapt to fight COVID while continue promoting essential newborn care. And I want to emphasize here the importance of interventions based on the community, and that Mamás de Rio could become a strategy for rural Amazonian areas in Peru and Colombia. So I want to thank to all the community health workers who have done a volunteer work for many decades, usually without recognition by the government. We hope that they can be inserted in the Peruvian healthcare system soon. These are the pictures of our last training. Also, we have a female power. Most of our core team are women. So I want to thank our supervisors and our coordinators who make Mamás de Rio possible. And also the persons who are doing the census are all nurses. They are now in the field evaluating and doing the final census of our program. And I also want to thank our 2 men in the team. Stefan Reinders, many thanks for leading the evaluation of Mamás de Rio. It's a huge work. And also Eugenio Guaman, who is our administrator. So with that, also I want to thank our supporters who have believed in us and has provided us with the funding that we needed to start from a pilot now to scale to a new country, Colombia. And thank you very much. I want to show you a video about the program. This is my information, and with that, we are going to finish the presentation. So I will show the video of Mamás del Rio soon once I upload the session. Good. So I will share the screen.
sobre qué quería escribir. Yo estaba segura que quería escribir sobre un proyecto que busque mejorar la salud de las mamás y los bebés en un contexto rural donde ni el Estado ni las instituciones privadas llegan. Y justamente me acordé de las mamás que yo había visto a lo largo de la ribera de los ríos y se me ocurrió ponerle Mamás del Río y enfocar este programa en agentes comunitarios de salud y empoderarlos a ellos para que con tecnología puedan mejorar la salud de sus comunidades. El asunto es que la Amazonía tiene uno de los peores indicadores de salud de nuestro país, sobre todo las áreas rurales que están a lo largo de la ribera de los ríos, que tienen más difícil acceso. En las comunidades donde intervenimos, el 65% de mujeres da luz en su casa, sin la presencia de un personal de salud entrenado. Y solo el 8% de bebés reciben un control del recién nacido.
Creo que realizando esta labor en mi comunidad no voy a permitir nuevamente que como me pasó a mí. Entonces, ¿cuál es lo que me pasó en ese momento? Es que cuando yo perdí a mi hija hace como 3 años atrás, en ese momento yo discutí fuertemente ahí en un centro de salud por la situación de mi esposa, más que yo quería, y cuando más dijeron que el bebé ya está muerto y no tiene vida. Para mí era un golpe tremendo. Creo que para mí, esto a mí me motivó y dijo, no quiero más que suceda en mi comunidad esto. Captamos a madre gestante, les damos charlas educativas para que las señales de peligros. Entonces, ellos se sienten también confiados. Y para que ellos lleguen confianza también, uno como agente comunitario también hay que saber llegar a nuestra comunidad, hay que saber conversar con ellos, porque ahora ellos tienen confianza, ¿no?, con uno, ¿no?, como agente comunitario que somos, quizás.
Mientras estábamos implementando Mamás del Río en las 84 comunidades en Loreto, recibimos una invitación del Ministerio de Relaciones Exteriores para presentar Mamás del Río para el Plan Binacional Perú-Colombia. Entonces estuvimos muy contentos de hacer esto y entonces Mamás del Río se transformó, una vez que fue aprobado por el Plan Binacional Perú-Colombia, en Mamás de la Frontera. Y ahora vamos a operar en 25 comunidades que están a lo largo de los ríos Putumayo en la frontera de Perú con Colombia. Y esta vez este programa se va a convertir en un programa que va a unir 2 países a través de la salud.
Mamás de la Frontera tiene básicamente unos nodos de implementación, entonces la idea en estos nodos es tener unos supervisores que van a ir acompañando el proceso de los agentes comunitarios. Prácticamente todas las comunidades tienen ya unos agentes comunitarios que están allí y pues la idea es empezar con el proceso de capacitación a sus agentes, de capacitación al entrenamiento al recurso humano en salud en coordinación con nosotros. El sentido de esto no es solamente fortalecer lo comunitario, sino que es muy importante la gestión que se hace con los servicios de salud y pues más en el marco de la apuesta de política que se tiene en el ministerio.
Lo que queremos es que Mamás del Río sea una innovación que pueda ser replicable y sostenible. Por eso es que hemos desarrollado procesos de todas las secciones que integran el programa, que se las vamos a compartir, por ejemplo, ahora a Colombia, pero también queremos que sea una intervención que pueda crecer en el futuro.
Creo que para mí apoyar a mi comunidad, apoyar a las madres, apoyar a los niños, yo me siento muy contento y feliz, me siento lleno de corazón porque lo realizo este trabajo con mucho amor.
Well, so that was the end, and I want to know if there is any question. Actually, I will look at the chat, but I don't know if you have any question. let me know.
Dr. Blas, for this great presentation. There's a question in the chat, in the Q&A chat box, and it says, is there any plan to integrate birth control in your program?
Oh yeah, I see. Yes, so one of the big things that we need is to implement family planning. There is a high percentage of adolescent pregnancy, and actually we are going to have actually one student from your university coming to Peru for a Fulbright to elaborate this, to study what was the impact of COVID in terms of unwanted pregnancies in the area of operation, and designing a route of how or what we should do to start this, which is a new area and a new complete project. If we know that, for example, in rural communities, adolescent pregnancy is not seen as a bad thing, no? It is something that happens in your life. So it's a very difficult and complex problem, an issue, and we plan to assess this. So there is another question from Purnima. What happens to women who have some issues in the postpartum period? If we train the community health workers to manage this, we don't train the community health workers to manage this. We're not still at this stage. What we do is to train the healthcare centers in essential newborn care, and we rely on the Regional Health Direction of Loreto, which they have a program to manage postpartum, for example, postpartum hemorrhage. So that is what we do in the program.
I have a question. Can you hear me?
Yes.
Is there a transportation program in case of any complications to where they can be able to get access to more comprehensive care?
Well, in Peru, what we have done is to report any emergency which previously were not reported to the Regional Health Direction of Loreto, and they conduct an action. Yes, the Ministry of Health in Peru has funding for transportation by river or by air. So we have had instances in which a woman was transported by a seaplane. So yes, the Ministry of Health does that, and they have funding for that, and that is covered within your insurance, which is a public insurance in Peru.
Okay. That's very interesting presentation, by the way. Very interesting project.
I have a quick question, and my question is related to recruitment of community health workers and whether or not you have found any challenges. It looked, at least from the video, that some of these community health workers have some sort of personal relationship with a story or have been personally impacted by birth and some birth challenges. So I was wondering if you have any input on that.
So community health workers are usually, and we request is that they are chosen by the community in an assembly. Not every time happens this. I mean, the assembly, sometimes they are chosen by the leader of the community. But so in that way, we try the community health workers to be a representative of the community. Some of them have had, like Regner, the one who was in the video, this type of stories, but not everyone. And what they usually have is the willingness to help the community. And they do all of this for free. They are not paid for their time, although they should be. We didn't insert the payment because we didn't know if the government was able to make it sustainable, and also because we didn't have funding for this. But we are advocating for the community health workers to be part of the formal system in Peru, so to be part of the team, no, of the healthcare team in Peru formally.
Have any additional questions for Dr. Blas?
I don't know if I've missed this, but you mentioned that you're in 84 communities. Is there any plan for expansion to other areas?
Well, we are currently operated in 114. We have the 84 communities in Mamás de Río and 30 more in Mamás de la Frontera in the border with Colombia. Yes, of course, we depend on funding, but we plan to at least keep our operations because we are not going to have any more funding from Grand Challenges Canada. It was a 5-year grant and it ended this year. So we are going to have probably a supplement with another organization. Colombia has got funding from the Ministry of Foreign Affairs for Colombia to expand their operations there. So yes, we want to do that. At the moment, we're focusing on the evaluation of the program and on make it sustainable. I think for us, I mean, the biggest prize will be that Mamás de Río will be taken by the government, make it yours, and keep it along the years. That is what we are aiming for.
Okay. There's another question in the Q&A.
Oh, yeah. Another question. Are you considering to test your model in other parts of the world, global health? Lots of what you're doing is applicable to issues in Africa and India. At the moment, since there are other initiatives in Africa and India, at the moment, we are, of course, we want to learn and do exchange. I actually visited BRAC in Bangladesh, very amazing work that they do with community health workers. I would love to visit India also. But we would like to expand to our borders. I mean, working in the Amazon is already hard, and we are not even in 20% of the Amazon. We're working with 6 indigenous groups. We have 54 in Peru. So we would like to expand to Peru and to neighboring countries and make it sustainable. Of course, we would love to do exchange of our program and learn from other programs in other settings. I have learned a lot by going to Bangladesh. And yes, we would love to do that.
I just thought of another question. I mean, you mentioned, how the goal is to trying to have the community health workers be part of the system. What kind of challenges do you foresee with that? Because I mean, at least I can remember some of the work that we've done I used to do in South Africa. There was a lot of issues with certification and like scope of work and regulation of what they're doing. I mean, what kind of challenges do you foresee with that goal?
Well, expanding the training, the levels of education are very low in rural areas. No, the quality of education is incredibly low. So basically, teachers don't go to schools. So people don't attend schools, and the difference in a 5th grade in Loreto in a rural area is super different than a 5th grade in the capital in Lima or Iquitos. So we have to deal with that. And also to insert it, I mean, to be part of the health system, we will have to work a lot with, the other health professions like nurses or medical doctors so that they can respect the work of community health workers. Sometimes they don't take their work very seriously. And this is one of the reasons why we talk about this topic in the sensitizations of the healthcare personnel, to take into account the work of community health workers and respect their work. I will say that is, and also how to maintain the community health workers along the years. Yeah, in Peru, they don't receive any payment. So probably we will have to do a program in which they will have to receive a payment, but also a program in which they can grow along the years, like a career for a community health worker.
Yeah. Okay. Yeah, because I think they're very important in rural areas, and often it's the only option for a lot of people. There's, at least from the places that I've been to, there was a lot of people who were getting exhausted by, all of the pushback and regulations that they would receive in order to continue what they're doing. Even if a study had already exited the area, some of them would like to continue the work, but then they get all this pushback. So I just wanted to kind of see your experience with that kind of scale. Thank you.
Yeah, thank you very much. And if there is no more questions, I want to thank a lot for inviting me to give this talk. Actually, it's the first time I talk about the whole components of Mamás de Río. So thank you for the invitation.
Thank you very much, Dr. Blas, and thank you, the Global Health Alliance and the Global Health Institute, for helping organize this. We really appreciate and congratulations on this great initiative. Thank you.
Thank you very much.